All right, so here we are, ready for another episode of Coffee with the Founder. I got my coffee cup here from one of our favorite family movies, Zootopia, and uh, uh, we're excited because we also have here a good friend and colleague, Mary O'Connor, who I've had the good fortune to get to know and get to know better over the last year or so. And Mary, I am glad that you've been able to join us. What we're doing here is trying to give people a look, an inside look into the people who are part of my work, my network, but also the WPC network. And so we want to start by having you introduce yourself. If I was to meet you at a train stop or a bus stop or airport lobby, and I say, who are you? My name is Eddie. Who are you and what do you do? How do you explain or introduce yourself to people? Who do we have here with us today?
Well, Eddie, first of all, thank you for inviting me. I'm delighted to be with you and congratulate you for all the work and progress that you've made, because we have to all be in this together to make things better, right? So I am an orthopedic surgeon by professional background. I still see and treat patients, but the largest part of my job is administrative. I'm the director of the Center for Musculoskeletal Care at Yale School of Medicine and Yale-New Haven Health. And my passion and mission is to really transform the delivery of care to make it more patient-centered and value-driven and produce better outcomes. Part of that work also involves addressing disparities. I also am chair of Movement is Life, which is a multi-stakeholder coalition. We've been honored to have you there with us. And our work is focused on understanding and addressing the fact that arthritis and other musculoskeletal conditions disproportionately impact women and individuals of color. And never more so has this message been more important than what we're seeing with the horrible mortality disparity rates in this pandemic. And this all comes back from a medical perspective to comorbidities. And I think probably most people in the country now know what a comorbidity is, and maybe they didn't before, but now people understand that if you're obese with diabetes and hypertension and you get this horrible virus, and especially if you're older, your prognosis is much worse. And so as we try to unravel, why is it that women in our communities of color are sicker, essentially sicker, we can see that there's medical risk factors, and then there's social determinants of health that overlap that, and then public and private policies. And all of those things contribute to these disparities. And we need to fundamentally start addressing them and dismantling the infrastructure processes that contribute to these horrible outcomes, which is really complicated and very complex, but we have to have courage and faith that we can affect change, because I know we can make change for the better.
Yeah, thank you, Mary. I want to ask you if you could just describe the current state of the healthcare system. I mean, from your vantage point. But before that, I wanted to know, did you always want to be a doctor? Like, how did you get on this journey? And it seems like right now, you're really specific about what your work is all about. How did that come about?
Well, Eddie, I guess I decided I wanted to be a doctor because I liked helping people. I mean, I want to help people, and medicine fundamentally at its core should be about how we help each other. And then I decided that I wanted to be an orthopedic surgeon because orthopedics does stuff, you know, like it's a very active process where we do an operation, hip replacement or knee replacement, and we can see people get better, and they get meaningfully better. And my personality of vision, driving to completion, accomplishing the task, winning the race, is far more suited to that than managing someone with chronic disease, like a doctor who manages someone with diabetes. However, and in my journey, I came to see in my own practice how women and individuals of color don't receive the same care. And that, I would say, really started me on my own personal journey towards addressing the need for health equity and some of the systemic factors. So I just said, this isn't right. I mean, it's just not right. Why are patients not having their voices heard?
So what is the current state? You mentioned that there are some of these disparities and inequities. I know it's probably difficult to describe sweepingly all the numbers, but if you had 2, 3, 5 minutes to say, here's the current state of affairs when it comes to health inequities, health disparities, how do you talk about that in kind of a bite-sized version?
So Eddie, these are my personal opinions, right? I'm not speaking on behalf of my institution. These are Mary O'Connor's opinions. The healthcare system has failed. There's a lot of good people trying very hard to take good care of patients, but the system itself is inadequate. And one of my favorite sayings that I learned from someone years ago is that B teams with A systems will always beat A teams with B systems. You can have really smart people and a great team, but if they're in a structure of systems that is suboptimal, they will not do as well as people on a team who may not be all quite as talented or quite as smart, but are in a system where the structure is better. So right now, I see our healthcare system as we've got lots of A teams, lots of really smart, dedicated people. And we see that now with the healthcare workers that are putting their lives on the line to go take care of their fellow human beings. We see that. But they're working in this system that has created the scenario where so many of them are getting sick and so many people are dying, and we see a disproportionate impact on Latinos, African Americans, individuals that have higher comorbidities, individuals that live in denser housing, individuals where they're essential workers, particularly on a lower income scale. And so this is just compounding the visibility of the problems with our system. So the system has failed. I'm just going to put that out there. The system has failed. I also want to say something about insurance, because some people, I believe, have a misconception that if you have an insurance card, you have access. That is not true. You may have an insurance card through the Affordable Care Act, but that doesn't really mean that you have access, because we know that a lot of offices and physicians won't accept certain types of insurance. And the reason why they don't accept those insurances is because the payment is so much lower. So now we get into the whole money business and healthcare becoming a business as opposed to what it should be, which is how do we take care of each other from a health perspective? And one of my favorite sayings from a woman who was a nun and administrator at Mayo Clinic for years, and I was at Mayo before I went to Yale and trained at Mayo and have a lot of, carry my Mayo culture and heritage with me. So Sister Generose said famously, no margin, no mission, meaning if you can't make money, you can't keep your doors open. And so we have to, healthcare systems and have to be financially viable, or we can help no one. But the second part of her quote, which is often not included, is no mission, no need for margin, right? So we can't lose sight of the fact that we have to have a mission. And that mission is that we should be supporting health, wellness, healthcare in this country in a far more effective way. We have terrible health statistics. You know this. I mean, we spend an awful lot of money and we don't have the health outcomes data to show that that has been an effective investment.
So, Mary, as this COVID-19 rolled out, I think we all, or I don't know if all, I think many of us knew that there were some disparities, some inequities when it came to the healthcare system. But sometimes something shines a light on that makes us think, wow, I didn't know it was this bad.
It is this bad.
Did COVID-19, the results of some of what we're seeing, has it surprised you in any way? What's your sense of how you're feeling about what this pandemic has shown us, is showing us about the current state?
Eddie, I wish I could say I was surprised, but I'm not surprised. From my perspective, this was totally predictable. Because all we're seeing is the disparities that currently exist now being played out in this pandemic scale with people dying from the virus in a similar way to people getting sick and dying from other issues, but all related to the fact that people don't have good access to good care. We have totally inadequate preventative care and wellness programs. We have environments where people live that are unhealthy. And it's not just about medical care directly, but it's also about the environments in which people live. Is it safe for them to go outside and walk? Do they have grocery stores nearby where they can buy reasonably priced fresh fruit and vegetables? These are huge factors. Do they have to work 2 jobs to support their families? And I also want to make a point that, these factors are not isolated to our big cities. We see these disparities playing out in rural America as well. And I have come to see in my own mind that the overriding factor, the commonality here that links all of this is poverty. People that have no income do not get good health care. They struggle to eat healthy foods because they're more expensive. To buy fresh fruit and vegetables is more expensive than buying rice or pasta or potatoes. They don't move as much. They don't get as much exercise. So we know this. The data supports that income, education level are all linked to the health status of an individual. But it doesn't have to be that way. That's what we have to change. We have to change our mindset to say, it doesn't have to be that way. We can aspire that everyone can have good health, reasonable health, regardless of whether they ever graduated from high school or whether they're a PhD.
Mary, I mean, maybe I watch too much TV like The Nick and other kinds of shows that talk about the healthcare system from the past. It feels like when I think about healthcare and healthcare providers that when it comes to people of color, but as you mentioned, folks who have no income, the less fortunate, it seems as if the science was practiced on them and the results of the science was given to the super privileged, the super rich, the white folks primarily. And I mean, I don't know, it feels like, and you look at Tuskegee and Henrietta Lacks and that story and those stories, what's your sense of the participation of more diverse folks in the operation or the environment of medicine, so that we're having, at least, even though we're seeing some of these struggles, at least a more empathetic healthcare system to provide that care for more people and more diverse people?
So those are really important questions and comments. I'll start with one: we need more diversity in healthcare, certainly on the physician level. We have plenty of diversity if we look at the lower income jobs, which actually need more diversity. They're predominantly individuals of color, or they're higher percentages of individuals of color, right? So we need more physicians who look like the patients that they serve. I believe that will help patients be more engaged as members of a healthcare team, because we're past this concept that, oh, the doctor knows best, and I'm just going to go in and the doctor's going to tell me what to do, and I'm going to do just what the doctor says. First of all, people don't do that. And secondly, people have to trust that this is the right plan for them, right? The right approach for them. So they have to be engaged with their physician, and we have to have extended teams where we have nurse practitioners, PAs. I mean, it's no longer just a physician as part of that team, and the patients need to be engaged. So I often see women who are obese, who have horrible knee arthritis, and they come to me in my professional role as an orthopedic surgeon because they need knee replacement surgery. And I'm not the first physician and surgeon that they've seen. They've just been put off because nobody wants to operate on them because they're higher risk, because they're obese and they have diabetes and hypertension. They're going to stay longer in the hospital. That's going to negatively impact how I, as a surgeon, perform in our fixed cost bundle at the hospital. So we see all of these biases playing out, because when we go to policy, which I mentioned as that ring surrounding social determinants of health and the medical vicious cycle, right? We created these bundled payment models that don't risk stratify. So this was a huge misstep, in my opinion, because it puts people who are less favorable at a disadvantage. And those less favorable people are women and individuals of color. In terms of research, yes, we have that horrible legacy of things like Tuskegee. But we also have to remember that it hasn't been that long ago that people actually started to say we have to make changes and we have to focus on having diversity in our research studies in terms of patients. Because the vast majority of clinical research trials have been done with men, and women have been left out, with researchers saying the reason why we're not going to include women of any color, no women, well, it's, women are just too complicated. They have hormones and they have this and they have that, and men are just easier to study. But drugs work differently if you're a man or a woman. And so we see most of the drugs that are actually pulled off the market after they've gone through the whole and very rigorous FDA process are pulled off because of negative outcomes for women. So again, this comes back to bias, conscious and unconscious bias in how we're approaching creating new treatments, models, research, and delivering healthcare. And we need to be inventive. I like to use the saying that we need to leave sick care in the doctor's office and move wellness care into the community. When you go see your primary care doctor and you have 15 precious minutes with that physician, right? How effective is that at really having a conversation with you about exercise or eating well? Are you sleeping? Are you getting enough sleep? How's your stress? They don't have time for that. That is where the system, the structure of the system, doesn't support what we need to do in terms of improving health in our communities.
Well, I want to ask you a little bit about Movement for Life, but before I do, I was going to ask you about healthcare providers in the training, because you mentioned bias, unconscious bias. I'm wondering, are you seeing more of that training, more of that teaching being involved into and being involved in the process, becoming a physician, or is that still kind of extracurricular that they have to learn on their own?
So Eddie, there are some advances in that, and more recognition and acknowledgement that we need to train our healthcare providers, nurses and doctors, in unconscious bias and how to combat that. And we all have it. I mean, it's part of our human condition. But the first step is recognizing it. And oftentimes, if I'm speaking on this topic and I'm at a big orthopedic conference, and the audience is orthopedic surgeons, which I'll translate means mostly white males, okay? And I say, okay, how many people here like to operate on an obese patient? Raise your hands. Of course, nobody. I mean, if you had your choice as a surgeon between the obese patient and the skinny patient, it's a lot easier to operate on that skinny patient, okay? I mean, there's less physicality involved. It's harder physical work to operate on a big patient, and there's higher risks of surgical complications. So right there is an understanding that there is a bias that we have against obese patients. Now, let's just add on top of that race, ethnicity. Okay, we're going to layer it. Now what do we see? Now we see the obese African-American woman coming in to see that white surgeon. He looks at her and says, you need to lose weight. Go lose weight, and then we'll think about doing your knee replacement. Now, he doesn't really want to operate on her because he's obese. And maybe there's some discomfort because he can't see her as a person as much as maybe he could see her as a person if she was the same skin color as him. Because maybe he could relate to her more if she reminded him of his sister or his mother, right? I mean, when we make the human connection and we see each other as humans, as children of God, as alike, more alike than we are different, then it's easier to combat some of these biases. So that's the work that we have to do. And we, at the same time, have to empower those patients to say, I have struggled with my weight my entire life. This is what I hear from my patients, okay? I can't walk now. If you go out and tell me that I have to lose 40 pounds before I can have surgery, you tell me how I can get the resources to help me do that when I'm on Medicaid and I can't get into a bariatrics program and I struggle on a fixed income to go buy fresh fruit and vegetables. These people are trapped, Eddie, they're trapped. And that is a problem. I mean, that's our system. That's why I say the system is broke. It's failed us.
Yeah. Can you speak to your institution specifically, like the doctors you produce? Do you feel good about your work around building their cultural competence, battling, challenging their biases, conscious and unconscious, in the circle of influence you have? How good do you feel? How strong do you feel about saying, hey, if you come through Mayo O'Connor, you better believe you're going to have to deal with some of this stuff?
Well, Eddie, I try and remind myself of that saying of Mother Teresa, that we can only make small steps. I don't remember the entire quote, but it's always moved me so much, which is basically like, each of us can make small change. But when each of us makes small change, that makes a big change. And so that changes the mindset from this is an insurmountable problem and we just can't do anything and we throw our hands up in frustration to, no, I can make change. So I'm very fortunate. We have a very diverse residency program at Yale. We have historically been very diverse. The first African-American orthopedic surgeon was trained at Yale. We train a lot of women and women of color. So we are better off, and I would say more advanced than some others, although there are other programs that have a lot of diversity too. And that's interesting because in one of my prior leadership roles for our academy, I had residency program directors ask me how they could improve their diversity. So they had a program where there were just young white men in orthopedic surgery training, and they said, and the leadership said, we don't want this. We do want to be more diverse. But it's sometimes hard to get that first woman, that first individual of color, because if you were them, why would you want to go to this program that is so homogeneous, right? Mm-hmm. I mean, there's a lot of work being the trailblazer, which, I have been the first woman member of many orthopedic societies. I can tell you, there's a lot of work being a trailblazer. And if you had an alternative, you would choose that. So there are people that do want to make positive change, and sometimes it's hard, but we focus on diverse training. The more diverse your training program, the better, because people learn from each other. I will not let anyone on my team call a patient fat. We don't call people that. That's not appropriate. I say they're obese, okay? But we work on I work a lot with my team on the language that we use, because the language that we use reflects the mindset that we have, and the mindset that we have impacts the decisions that we make.
So can you talk about movement and the organization, the mission, vision, how you got involved? I don't remember if you're the one that got it started, but just give us a sense of what is Movement is Life.
So I'm the chair. I'm honored to be the chair of this group, Movement is Life. We started it 10 years ago. I was the chair then, so I've been with this from the start. I've had a couple co-chairs from time to time, wonderful individuals that then had to change because mostly they took a different job and they weren't able to continue to serve as a co-chair. Our focus is getting people to understand how important movement is, because if you move, you stay healthier. And we know that, we call it our medical vicious cycle, which I'll just briefly go through. If you get joint pain, then you become less active, but you keep eating and you gain weight, and that weight puts more pressure on your joint, and you get into this cycle and you end up with knee arthritis. But that's not the only thing that happens to you. That obesity and immobility give you diabetes, hypertension, heart disease, and depression. And that medical vicious cycle, Eddie, is actually an equal opportunity employer. The white male CEO can get trapped in that cycle, just like the low-income woman of color. But women and individuals of color are so much more likely to get trapped. Why? Because around that medical vicious cycle are the social determinants of health that I mentioned, right? Poor health literacy, unsafe neighborhoods, food deserts, et cetera, et cetera. And then around all that are policies. So we have policies that expanded insurance coverage for patients with the Affordable Care Act, but sometimes not in ways that actually allow them to receive good care, because not everybody takes those insurances.
So, Mary, if you have people who are willing to listen to you, what would you say to them? Let's start with a future healthcare provider getting ready to enter the profession the next 25, 50 years. What would be your word of advice if you were addressing, let's say, a class of 2,000 future healthcare providers?
My I think the most important thing I would say to them is that we're all connected. And if we just see each other as someone in our family, someone that we know, someone that we love, and try to provide the care for them that we would want for ourselves and our families, we would just be so much better off. I mean, that is essentially is the golden rule. And we should work to not accept the structural inequities that prevent us from providing that type of care to everyone.
Now, I would ask you what you would say to people in my neighborhood, but you saying it might be received differently than me saying it. I think what I'm asking is, if you're talking to people who may be in high-risk situations, whether it's cross class, poverty, race, gender, or a combination of those things, and really you're talking to them at 20, 30 in a preventative state of mind, what are some pieces of advice you would say to folks or advise people to say to their communities so that we can begin to push back and challenge and battle against some of these disparities around obesity, around high blood pressure, around, some areas associated with, what you were talking about with joints and
Right.
orthopedics and movement, so on and so forth.
Well, Eddie, I think there's a couple things. First, I really believe in the power of community. And I think that the more that we engage communities and empower communities to support health and wellness of the people living in those communities, the better off we're going to be. The healthcare system should really focus on taking care of people when they're sick, okay? But preventing people from getting sick needs to move out of the doctor's office where we do it really poorly, okay, and into communities. So let's empower communities. Let's say be responsible. Let's step up. Let's create a walking program. If we don't have a grocery store in our neighborhood where we can get fresh fruit and vegetables at a reasonable price, let's go talk to the mayor. Like, we shouldn't accept these things. And all the communities should support that community. It shouldn't, I don't like to see this as us versus them, affluent versus non-affluent. Because if there's one thing that this pandemic, I think, has exposed, there's many things it has exposed, but one thing is how interconnected we all are. So I say to people who are affluent, these people that are getting sick, these less privileged individuals, you depend on them. You need them. And they're the people who deliver the goods to your house, okay? You cannot completely isolate yourself. All the money in the world will not completely protect you from being exposed to coronavirus. So we're all in this together. We need to improve the health of everyone if we're going to be healthier, protect ourselves and our families. So I really see this as we all have to recognize how important it is that the baseline level of health improves, okay? Why do we have to shut down the economy? To flatten the curve. What does flattening the curve really mean? Here's what it means. It means the hospitals are not going to get overrun. It doesn't actually mean that fewer people are going to die. What it means is that we maintain the capacity of hospitals to provide the care that the sick people need. We have to not have as many people get sick at the same time. That's flattening the curve. Everybody needs hospitals. If you get sick, the CEO who gets sick needs a hospital, just like the low-income person needs a hospital. So there's so much that we all need. And if we focus on those commonalities, then what I hope would happen, for example, if that community goes to City Hall and says, we need your help and support, can't you get the grocery chain to come and put a store in our neighborhood? Can't you make this part of a larger plan if they want to expand, or they want tax credits, or they want this, or they want that? And have everyone support that, because everyone would understand the value that it brings to them and to those communities.
Well, Mary, I think one of the things I thought when I saw you on the main stage, kind of introducing Movement is Life and getting the program started is, I mean, not everybody likes you around because of the truth you tell. So I'm wondering, what are the costs? What have been the costs of doing the work of medicine that's inclusive, that's all inclusive? Because I can imagine at times you put a couple burrs in people's saddle. What have been some of those costs, and how do you take care? What's your self-care mechanism as you continue to push for a kind of access to healthcare that's not often associated with the design of healthcare?
Well, Eddie, what I do is I just I just ask for divine help. I mean, that's my source of support. And this might be a little more religious or spiritual than what some of your other guests may say, but for me, that's my source of strength, because I know that I'm here to make a difference, and I just can't worry about the other stuff. You know, I mean, I can't let it distract me. And part of that, I think, is I'm older and I'm more thick-skinned, and I know that what I'm doing is right. And so everybody won't agree with you. Everybody won't see it your way. But if I can at least get them to listen, a lot of them will have a different perspective. And that's how we make change, because we really need to make change together, right? I mean, that is the ideal way to do it. And so that's what I do. I mean, I look for strength from Divine Mother, from the big healer in the sky. I focus on what I think is important. And then I practice small steps of change to build my resilience and courage. I'll give you an example. A while ago, I had a medical student, and we did a study looking at the terms chair and chairman across different medical specialties. And this has always been a little bit of a sensitive subject, because I'm one of the few women that has been a chair of an orthopedic department. And so every time I see the term chairman, right, I just bristle inside. I'm like, what the hell? Excuse my French. Like, really? Why are you using this gender exclusionary term? Why can't it just be chair? Should just be chair. So I started calling people out on it. So I would get an email from someone, and on their title, it would say chairman. I would write to them, and most of the people I knew. Now I'm starting to do it with people I don't know, okay? So I would write, and I would say, Dear Bob, I noticed that you use the title chairman. May I respectfully suggest that you use the term chair? It's an inclusive term. It combats the stereotype that only men can be leaders, which of course we know is crazy. I have not had one person respond to me telling me to go take a hike. And so I really think that if we approach people as individuals in a respectful way, that we can affect change. Now, I know that's just one small thing, right? But it's still a step forward. I did this 2 days ago with someone I have never met this person. He's from France. I'm on an email with a whole bunch of international surgeons, and he sends this response, chairman. So I write back to him. I send him a copy of my article. He writes back and he says, wow, I never actually thought of that. He said, well, why wouldn't we use the term chairwoman? I said, well, you know, some people don't identify as one gender or another. That's one reason. Two, it's just simpler. Chair. It's to chairman, chairwoman, chair them. It's just chair. It was like, okay, I get it. So, I mean, so that's just a little example of stepping up and saying, no, we don't need to do this. And the more that we can do that, the more we can say, we're going to address disparities. I sent an email 2 days ago to some of the surgical leadership saying, when we reopen for elective surgery, how are we going to ensure that the patients with less favorable insurance are not disadvantaged, right? Because the hospital has taken a huge financial hit, physicians have taken a huge financial hit, and it would be logical if you were just looking at it from a financial perspective that you would take first the people that are going to pay you more. But that's not the right thing to do. And so calling it out and raising the question and saying we should have a plan, an expectation that we're going to be equitable in how we allow patients to get elective surgery, being blind basically to their insurance status, is an important question we should be asking in medicine as we're going to come out of this pandemic and get back to something closer to normal.
Wow. Mary, what are you going to be when you grow up? What's next on the horizon? The next 10 years, as you look at your work, doing the work, what's on the horizon for Dr. Mary O'Connor?
Oh, Eddie, thank you. That's a great question. I'm not sure where Spirit's going to lead me next. I know that I'll continue to focus on health equity, focus on transforming the models of care and the delivery of care. There's still a lot of work I want to do with Movement is Life. So I'm excited. I have a lot of interesting things. I'm very blessed that I have so much work that is so meaningful to me. And that's really, I think, another thing I would tell those young healthcare people in the audience. You asked me the earlier question. Find work that's meaningful to you, because then it sustains you through the good times, the bad times. So I'm very blessed. I mean, just look at you. I get to have this conversation with you. How lucky am I?
Oh, this has been really informative for me and inspiring. I know a little bit more about your story than others know, and all that you've done, that you're doing, and sounds like you will continue to do. And I'm just so fortunate and blessed to have you come into my circle of influence, and thank you for all you've done, and thank you for being here. We'd like to end on a little lighter note. I'm not sure if you're having any extra time, but what we're finding, people with some extra time have had a chance to catch up on a show, binge on a show. Are there any shows that you've watched that you'd like to add to our "you should see this"? We're collecting them from our participants. Anything you've watched that you've learned from, any streaming, or anything that just kind of allows you to just get away for a minute?
So my oldest found this show, I think it's on Netflix, but don't quote me, called Letterkenny, Letterkenny. And it's this crazy Canadian show about these people in this little town. And it's just funny. And it's just such a distraction. And we watch it together in the evening. And so that's been enjoyable. And one of the blessings in this in our current challenging of the pandemic is that 2 of my 3 children are home with us right now, and that's been wonderful to have them back here. So I would put Letterkenny if you want something funny and light and completely non-pandemic related.
Great. That's great. We have not had that suggestion, so this is why we're asking. So thank you for adding to that list. Mary, can you please get your keynote speech ready for white privilege? Because your invite is coming soon. I
Uh,
really feel like we need something around medicine and the subject of privilege on the main stage. So I'm just giving you fair warning that we're going to call on you. And I really want to talk more about what you've been doing with chairmen, because I've been having that feeling around chief executive officer and trying to advocate for First Nation folks to have that title kind of removed and maybe do president or executive officer or something. So I'd love to take a peek at that letter you're using as a way to maybe partner with that initiative, because that, you're right, it's something little, but it can impact generations of people to come.
it's about the culture, Eddie. You know, if we had a culture where we weren't talking about privilege, whether that's white privilege or male privilege or education privilege or whatever the privilege is. And I know I'm not trying to be unrealistic, of course. We're always going to have some people that are better educated than others because some people are innately smarter than others or have more desire for education than others. That doesn't make them better or worse or more valuable or less valuable. But there are differences because people are different. But as we look to a society where we're not talking about privilege, but more talking about opportunity, that will be a glorious day.
Yeah, yeah. Well, I will agree to be in collaboration with you to move towards that as long as you'll have us. And we hope that you will continue to be a partner. And we appreciate your time, Mary. Thank you very much.
Eddie, God bless you. Thank you, and be well.
All right. Take care. Peace, peace.
Peace, peace.